Greetings, this is Doug Watson, Technical Director for DelphiCare. DelphiCare is a comprehensive clinical decision support system for longitudinal care of HIV-exposed and HIV-infected children. Led by the University of Maryland, it is the collaborative effort of clinicians experienced with maternal-child HIV care in Zambia and developers of clinical decision support for the African setting. This video provides a brief demonstration of the DelphiCare system. We will first hear from Kennedy Sambambi, coordinator for DelphiCare, present an overview of DelphiCare and our approach to implementation in clinic. Next, we will hear Stephanie Cott, program manager, describe the patient registration process and demonstrate DelphiCare support for care of an HIV-exposed infant. Finally, I will show how DelphiCare guides the care of the complex case of a 6-year-old boy infected with HIV. These brief presentations are just examples of the many clinical scenarios that clinicians may encounter in practice and for which DelphiCare provides comprehensive guidance.
In my practice, I have noted that many children who are HIV exposed become infected along the way and are not diagnosed on good time. The infected children end up with HIV-related complications due to poor monitoring. CDS will play a major role in addressing issues of poor monitoring and delayed diagnosis. The example I give here is DelphiCare Clinical Decision Support System for care of HIV-exposed and HIV-infected children and adolescents. As you all may be aware that virus ablation is achievable with available drugs and is necessary for a long-term health. Children in Zambia and elsewhere have a low viral load suppression. The cascade of pediatric HIV care shows that lost opportunities, most notably failure to diagnose and failure to achieve and maintain viral suppression. How do we then achieve a high standard of care and adherence to guidelines under conditions of 1, dispersed decentralized system, constraints on number, training, and support for healthcare workers? The answer is DelphiCare. DelphiCare supports care of HIV-exposed infants and HIV-infected children and adolescents. DelphiCare is comprehensive, offers longitudinal care, it's complex and simple to use. DelphiCare guides clinicians through the clinic, displays information, makes recommendations, but above all, the clinicians makes the final decision. It empowers clinicians in local clinics, mostly nurses, to confidently manage complex cases. DelphiCare as a system, it runs offline and uploads data only when it's connected to the internet. Its intuitiveness flow minimizes training requirements. Lower level workers can handle high complex cases. Updates of reflecting changes in guidelines are pushed only when connectivity is available. DelphiCare offers real-time program. DelphiCare training model is localized, planned at the local setting to avoid movements of facility staff. It's also used as an electronic health record. It's a standardized program embedded on an Android tablet, which fits in the hands and easy to move about with. What have we learned about how to successfully develop and implement a complex CDS system? It has to be user-friendly. Logic written software is very essential. Expert clinicians must write the logic. It's just too complicated to hand to a programmer. Work with the system available. We have to work with the provincial, local leadership, the district, and the facility staff. Facility staff will not accept the CDS if they have to put information into system and continue to use paper records. Above all, for DelphiCare to be successful, it needs a team of committed, diverse individuals to provide teamwork. Thank you.
Stephanie Cott will now walk us through the care of an HIV-exposed infant in DelphiCare.
An MCH clinician begins the day by logging in with her unique account. She navigates to the Exposed tab where she sees the listing of all HIV-exposed infants registered to the facility. Moses Monza and his mother have come in for Moses' first visit with DelphiCare. The clinician opens Moses' file and sees all his information. The clinician then navigates to the Visit tab, and the visit begins by gathering relevant mother information. Moses' mother is in attendance today. She's currently on ART, and she started her course of ART back in 2018. The mother has had a positive HIV rapid test result and did receive ARVs in labor. In her current regimen, the mother is taking tenofovir, lamivudine, and efavirenz. The mother has had a viral load with a known result, which was done back in March before Moses was born. The viral load came back undetectable and was done when mother was on her current course of ART. The mother has been adherent to her ART over the past month. Next, the clinician can enter today's vitals. Basic information about the child is collected to help guide care and inform the clinician's decision-making. Based on this information, Delphi calculates and displays relevant information such as weight for height and weight for age z-scores and a colored chart to indicate how the child is growing. Now we begin the visit. We begin by reminding the clinician to enter all test results and medications for Moses. No PCR sample or result is recorded for Moses, so we ask if one has been sent. We then review Moses' information, such as his demographic and vitals, and also review mother information, such as her ART and test results. We look at Moses' current medications and assess for acute illness. Assessing acute illness helps Delphi decide what diagnostic category a child may fall into and helps rule out presumptive infection. Moses is well and has none of the above issues listed. Moses' father has been disclosed, and his mother is disclosed to other people as well. Moses is exclusively breastfeeding and has a preliminary diagnostic category of HIV exposed but at low risk of acquiring HIV. We're directed to order a PCR test for Moses and are given more information about his diagnostic category. Moses is HIV exposed but at low risk of acquiring HIV. Counseling information is given for both the clinician and the family. Delphi determines that Moses is malnourished. It gives counseling messages to the clinician and to the family because he's not growing well despite exclusive breastfeeding. We're directed to order a viral load on the mother because her last viral load was done more than 3 months ago and before Moses was born. Medication information follows, and we're directed to discontinue antiretroviral prophylaxis. If we have a question about this screen, we click the gray question mark in the top right and additional help information pops out. Anytime there's a gray question mark, we can click it to get additional help information. Cotrimoxazole is prescribed for Moses, and the formulation and dosage are automatically calculated based on Moses' specific needs. We're reminded of Moses' immunization schedule and given an approximate return to clinic date. However, ultimately this decision is up to the clinician who decides when that return to clinic date will be. We're reminded to order a viral load on the mother and a DBS for PCR for Moses. Finally, the clinician can enter any additional information that they'd like to be reminded of in the next visit or on the past visit screen, which we'll see later on. Once the visit is complete, the clinician can navigate back to the dash and see information we just entered in the visit. This includes the mother's treatment regimen, viral load result, disclosure information, as well as the child's updated medications, feeding status, weight for age and height, and even the pending PCR result. Later on, Moses' PCR comes back, so we click the floating action button to enter the result. The floating action button allows us to add, edit, and delete test results, medications, immunizations, information regarding family members, and more. If we begin by clicking medications, we can see all medications Moses has ever taken. We see that AZT3TC nevirapine was stopped on June 10th and that Moses is currently on cotrimoxazole. Going back to the dash and the floating action button, we can now enter Moses' PCR result. Moses' test was done on June 10th, and there was only a PCR done that day. The result came back negative. We see the result appear in the listing, as well as on the dash, showing green, indicating a negative result, as well as the date of the test. If we scroll down the page, we see that the test no longer appears as pending and is now showing as a result. Now let's pretend a new clinician is seeing Moses for his next visit. This clinician is curious what happened during Moses' last visit, so she navigates to the Visit tab and clicks on the most recent visit. We see information about the visit, mother information, medications prescribed, and tests recommended, as well as the clinician's notes from the previous visit. If Moses had multiple visits, we would be able to swipe right and see all previous visit information. To conduct a visit with another patient, we navigate back to the exposed listing and can begin again.
I will now demonstrate care of an HIV-infected child in DelphiCare. This is the case of Jacob Peary, a 6-year-old boy diagnosed with HIV in May 2015, at which time he had a CD4 count of 22%. The dashboard gives us his current medications, today's weight, weight for height, weight for age, and the most recent CD4 count, and viral load, which is in red because it is elevated. He was started on abacavir 3TC and lopinavir at the time of diagnosis. The CD4 count went up to 31%, and then drifted down to 19% by October of 2017, at which time he was started on AZT3TC and efavirenz. The CD4 went up to 23% by May of 2020. However, in February of this year, the viral load was 15,700, and a repeat in May was still elevated at 5,200. DelphiCare has determined that there is probable resistance to lopinavir, efavirenz, and abacavir. He had been on cotrimoxazole, but this was stopped in 2019 when his CD4 count had risen. We also see on the dashboard that his mother and father are on ART, but that he has a brother, Luke, with an unknown status. We confirm that he takes medication once a day, currently is not missing doses, and has been on ART for at least 6 months. We review his current symptoms, including fever, which he has had for 10 days. He's also had decreased activity for the past 10 days, and he's had a cough for the past 3 weeks. Cough is not getting better, and then after a course of antibiotics has not improved. He's not been in contact with anybody with tuberculosis. We also run through other possible symptoms, and the parents have noted that he's had weight loss. Mandatory physical examination. We count respirations using a respiratory rate counter. We press the start button and press the plus button every time we observe the child breathing. An alarm goes off at 30 seconds to tell us how long we've been counting respirations. The development screen is done on schedule, checking to see what his gait is, whether he's in school, and if not in school, we review milestones appropriate for his age. And in this case, Jacob has appropriate milestones. We observe his breathing. It appears normal. We look for other physical signs. Note that he has wasting. And a physical exam is done. We mark the systems that are normal and note that the lung exam is abnormal. On the genital urinary exam, we can also mark his Tanner stage. Because his lung exam was abnormal, we make note here of what the specific abnormalities are to be available at the next visit. DelphiCare tells us that there is a problem because his viral load is up and his CD4 count is down. We review adherence and the main adherence points for a child this age. He does not have problems with refusing medication. We go through a checklist to make sure that the basic adherence elements for a child have been met before we embark on any change in therapy. And we are satisfied that the parents understand the situation and can adhere, and we want to continue with ART. DelphiCare notes that he has a constellation of symptoms suggestive of tuberculosis and recommends that he also notes that he is at high risk for tuberculosis because of the elevated viral load and low CD4 count. Testing is recommended, and we indicate that we want to do all the recommended tests. We have the option of doing these at point of care tests, and in this situation, we're going to get a chest x-ray today, but the gene expert and TB smear will have to come back later. We pause the process to get the chest x-ray. When he returns with the chest x-ray, we note that there is mediastinal adenopathy and that an infiltrate is present. And most importantly, these abnormalities suggest tuberculosis. DelphiCare suggests that there's tuberculosis, but wants us to consider other possible diagnoses. And the user confirms, yes, we believe it is tuberculosis present in the lung. He's not had close contact with anybody with resistant tuberculosis, and we confirm we want to start TB treatment. We are given the details of the medications and dosages. ART is recommended to change to zidovudine, lamivudine, and raltegravir, with the information on which this is based summarized, and details of the medications, the dosage, and possible side effects. In the case of raltegravir, it will be noted that if it is not available at the current site, he may have to go to another site. Cotrimoxazole is recommended to be restarted, and we record if we need to make any referrals. The recommended tests are reviewed, and we confirm which one of these tests we are sending, so they will be marked as pending in DelphiCare. DelphiCare will automatically update his medications, and we can make note of our assessment and our plan and the important points that we feel are going on with Jacob. DelphiCare recommends that he return to clinic no later than 2 weeks, but when he returns is up to the user, and in this case the user decides that he wants to see Jacob back next week. So we pull up the calendar and mark the date for his next appointment. The database is now updated, and there's an optional user feedback survey at the end of each visit. Thank you, and please let us know if you have any questions.